Good morning, everyone. I'm Dr. Akshay. I'm a pediatric intensivist and I work at Rainbow Children's Hospital. And on behalf of Rainbow Children's Hospital, Martha, I welcome all of you for this global grand rounds. The idea behind the global grand rounds is to understand the international practices and the experience with on the topics which are relevant to us, and hopefully that might help us learn better and understand better. And for the first edition of our Global Grand Rounds, we are absolutely delighted to have an expert on infectious diseases from Boston. And I would request Dr. Manu Chaudhary, who takes care of our ID services at Rainbow Children's Hospital, to welcome our speaker and give an introduction. Over to you, Manu.
Thank you, Dr. Akhtar. So I take this pleasure to introduce my very dear friend and colleague for last couple of years, Dr. Gabriella Lamb. She's an assistant professor in medicine, Boston Children's Hospital. She's an instructor at Howard Medical School in pediatric infectious diseases, and she's director of quality improvement at Division of Infectious Diseases at Boston Children's. Dr. Gabriella Lamb did her biology from Boston University, and then went into doing tropical medicine from Baylor College of Medicine, along with medicine MD. She did her pediatric residency from University of Texas Southwestern Medical Center at Dallas, followed by Pediatric Infectious Diseases Fellowship along with me from Texas Children's Hospital. Along with her fellowship, she did her MPH membership to various professional infectious diseases society, including Pediatric Infectious Diseases and IDSA. Her research is focused on tuberculosis. She's very much interested in global health and a lot of quality improvement projects. And we discuss a lot about global health. And this seems to be our first venture collaborating together on the same lines. She has published a lot of interesting papers, including on COVID and MISC in the recent times, and has had multiple presentations at various infectious diseases society meetings. It's a great pleasure to have you here today, Dr. Gabriella Lamb. I hand over the discussion to you now.
Thank you, Manu. Good morning to everyone there. It's evening here. I wanted to thank you for the invitation to speak with you. I'll just reintroduce myself very briefly. My name is Gabriella Lamb. I am an assistant in medicine at Boston Children's Hospital and instructor at Harvard Medical School in Pediatric Infectious Diseases. And today I'll be discussing the Boston Children's Hospital experience with COVID-19. I have no financial disclosures to discuss. So first, I would like to review the objectives of this talk to give us a little bit of an introduction of where we're going. So first, I'm going to review the timeline of COVID-19 in the United States and how it spread and eventually set roots in Boston. Next, I'll explain how we organized our response and go into a lot of the logistics. Followed by that, I'll discuss our approach to diagnostics and therapeutics, and then review our vaccine rollout processes. And then lastly, I'll discuss some of the novel programs that were developed in response to the pandemic. First, I'm going to briefly review the early timeline of COVID-19 in the US and how and when it first arrived in Boston. So on January 17th of 2020, the CDC, or Centers for Disease Control, deployed a team to Washington State. This is actually 3,000 miles away from Boston, to assist with contact tracing efforts in response to the first reported case of COVID-19 in the United States. On January 20th of 2020, the CDC confirmed the first U.S. laboratory confirmed case of COVID-19 in the United States. Cases quickly increased in Washington State, and in February, residents reported symptoms at the Life Center in Kirkland. And this is really where a lot of our news was centered. And most of this was happening about 20 miles from downtown Seattle. So as COVID-19 continued to spread to the Western US, we started to see cases in other areas of the US, but mainly coastal areas. So we were seeing on the West Coast, and then in the spring, we started to see cases on the East Coast. So on March 1st of 2020, I was actually on a train riding back from a trip to New York, back to Boston, when the news came out from the governor that the first confirmed case of COVID-19 happened in New York City. And as many of you know, this was followed by a very aggressive and early surge in the pandemic. Shortly after the first case in New York City was announced, on March 4th, the Massachusetts Department of Public Health was contacted with a report of 2 executives who had attended the Biogen conference in February, that they had tested positive for SARS-CoV-2. And then more recently, looking into the outbreak that occurred as a result of this Biogen conference, there was a study that was published in Science in February of this year, shown here on this slide, that used genetic sequencing and demonstrated that as many as 330,000 people worldwide have been infected with SARS-CoV-2 as a result of this 2-day conference. As with New York City, shown in this epi curve of cases in Massachusetts, in the spring of 2020, we had our first wave of COVID-19 in Boston, and our first case at Boston Children's Hospital was in April of 2020. We were one of the parts of the US that had a very early and high surge, and given that we're a large pediatric referral center, we didn't really have the luxury to wait for more details or information to make plans on what we were going to do. So we had to really quickly develop plans for things like infection prevention and control, treatment, and how we were going to adjust our staffing. So stemming from this, I'm going to go into next how we organize the logistics of our response and specifically focus on, in this section, what was done from an infection prevention and control standpoint. First, I would like to highlight the amazing work of our infection prevention and control team, who really took the lead in so much of our COVID-19 response. They worked really extremely hard and implemented many measures that kept our hospital safe. And fortunately, we to date have had no cases of hospital-acquired COVID-19. So one of the first steps that was taken was a team of leadership from infection prevention, nursing leaders, hospital administrators, and other leaders in the hospital was formed, and they developed this group called the Incident Command Center or Hospital Incident Command Center. 2 of the key interventions that they implemented early in the pandemic were, first, actually closing off most of the entrances into the hospital to have a single point of entry, where each person was screened for symptoms and provided with a mask. And with this, we actually also limited the number of visitors accompanying a child admitted. This has since resumed to normal visitation policies. And then, as I alluded to, one of the second key measures was very early on, we did implement universal masking with surgical masks for all staff, patients that are able to, and parents. And then additionally, another issue we had to address was there was a nationwide shortage of N95 masks. So we had to quickly plan for ways to judiciously use our N95 mask supply and implemented a system to reuse our N95 masks, actually up to 5 times per mask, depending on the quality of the mask. And this was done through daily decontamination. 2 other key measures that were implemented to help prevent spread of infection were social distancing of staff members. So particularly when not wearing masks, such as when eating, staff members were instructed to eat in separate spaces, and new plexiglass separators were installed in eating spaces. And further, to ensure social distancing, there were major shifts in staffing of the hospital. Some specific changes in staffing included consolidating resident teams and having some of our residents actually work in local adult hospitals to help with the much more significant surge among adults. Specifically for our ID service, we typically have 3 teams, 2 teams that covered general infectious disease consults and 1 immunocompromised infectious disease team. During the spring surge and through the summer of 2020, we consolidated this to 1 general ID service and 1 immunocompromised ID service, and we're very intentional about which attendings and fellows were going to be covering the service to ensure that more vulnerable members of our teams were not on service during those times. Another major logistical shift for us was in where pediatric patients were actually cared for. So you can see a little bit in this map. There are actually many hospitals in Boston, and then even more so in the surrounding New England area. So throughout this early surge, we were in discussion with other institutions, particularly institutions that care for both adult and pediatric patients. So to help care for this really large wave of adult patients needing ICU level care, a lot of these hospitals converted their pediatric intensive care units to adult ICUs. And then we at Boston Children's Hospital actually took all of the pediatric patients for the area to allow for that shift in ICU beds. For the last portion of the infection prevention and control portion of this talk, I wanted to highlight some of the other critical work our infection prevention and control teams did. So firstly, the Hospital Incident Command team participates now in regular COVID-19 recovery group meetings to try to help get our hospital back to normal operating procedures. They additionally created an internal COVID-19 website with a variety of resources. They developed educational materials, including family education sheets, and created a new contact tracing team. We already had one, but they really built this up and had a specific one for COVID-19, and were able to add staff to make sure we had enough to facilitate contact tracing. And then lastly, they hosted regular town hall open meetings to address questions for people that work in our hospital. In addition to numerous logistical challenges to accommodate all of the patients and prevent spread of infection, we had to then determine how we were actually going to manage patients who we were concerned may have COVID-19, who at that time we were calling persons under investigation, or PUIs, and then how to treat those who were actually proven to be infected, given the minimal data on therapeutics at that time. So next, I'm going to discuss how we approached these challenges. First, I'll focus on how our institution managed our approach to diagnostics, and then after, I'll go through therapeutics. Early in the pandemic, there was a nationwide shortage of the nasal swabs needed to perform the SARS-CoV-2 PCR testing. So we actually had to be quite judicious with who we were testing. In order to do this, each patient for whom testing was considered required an ID consult. So the ID service was consulted and reviewed the patient's symptoms and exposure history. And then in consultation with our infection prevention and control team, decisions were made on which patients to test. Another challenge was that the labs were first only available first through the CDC, and then shortly after it, outside commercial labs. So every test had to be sent out of our institution. So combining this with the fact that a lot of people were sending tests to these commercial labs, there were significant delays in getting results back. which, as you can imagine, created a lot of challenges. However, thanks to our wonderful microbiology lab, we were able to pretty quickly obtain and validate in-house PCR testing. And with improvements in supplies, we were able to implement universal testing for each patient admitted to the hospital, as well as universal pre-procedure testing. And then lastly, for the diagnostics portion of this talk, I wanted to discuss antibody testing. It was the same issue earlier on where all of it had to be sent out. But eventually we were able to bring in in-house testing, and this became really critical as we started having cases of MIS-C, which I'll briefly discuss later in this talk. The next issue we had to tackle was what our approach to actually managing patients who tested positive for COVID-19 would be. So from a supportive care management standpoint, our institution gathered and led a multi-institution international collaborative of pediatric critical care providers to discuss, teach, and learn best management practices for COVID-19 as data continued to emerge. I've shown here on the slides one of these sessions. Several of these are actually available online on YouTube. And then to discuss, teach, and learn best management practices for COVID-19 as data continue to emerge. I've shown here on the slides one of these sessions. Several of these are actually available online on YouTube. And then regarding our approach to antiviral medications, very early in the pandemic, we did use hydroxychloroquine as it was the only FDA-approved intervention at the time. However, as data emerged or continued to emerge that demonstrated really no impact, and with the FDA approval of remdesivir, we quickly changed our therapeutic approach to use remdesivir in early May of 2020, and then added steroids, particularly dexamethasone, to our repertoire once data demonstrated its utility in June of 2020. We have written and published internal guidance on how we're currently managing patients with COVID-19, which is shown here. It gives the dosing and dose adjustments and monitoring for remdesivir, which we only use in patients with severe or critical COVID-19. And then this portion of the document shows our recommendations for steroid use and convalescent plasma. It provides dosing recommendations for a variety of steroids, hydrocortisone, prednisone, methylprednisone, and dexamethasone. And we have been using steroids for patients with supplemental oxygen requirements. And we've used convalescent plasma on a handful of patients, but it's been pretty infrequent that we have used that particular therapeutic. In addition to our internal guidance, which I've just showed you, we actually worked to help develop national guidelines as well. So here are the two of the articles that we worked with groups to publish. Stemming from the initial paucity of data, we created and participated in a multi-center working group to discuss and develop national guidance on the management of pediatric COVID-19. Shown here are the two articles we published with initial and then interim guidance on the use of antivirals for children with COVID-19. And these published guidelines, particularly the interim guidance, match with our current internal guidance. And then lastly, the most recent addition to the COVID-19 treatment repertoire, monoclonal antibodies, have been a key piece to our management of children, or for children who qualify. At Boston Children's Hospital, we initially had access to bamlanivimab, which was approved by the FDA in November of 2020, however, was revoked due to development of viral resistance in April of 2021, at which time we transitioned to combination bamlanivimab etesevimab. And then in May of this year, we transitioned to combination casirivimab and imdevimab, which is what we're currently using for our patients. We again developed internal guidance that was based on the FDA's emergency use authorization criteria for who to offer monoclonal antibody therapy to, which is shown here. From a logistical standpoint, there were several key measures that had to be implemented. So first, there was development of a multidisciplinary group that has to review each case that's referred for monoclonal antibody therapy to ensure, one, that they qualify, and two, to ensure equitable distribution. Additionally, determining where to administer the infusions was challenging because we needed negative pressure rooms. We've been administering infusions in negative pressure rooms in the emergency department. We have some dedicated inpatient rooms specifically for this purpose. And then more recently, we're able to acquire a room at one of our satellite hospitals. And lastly, we've used our infusion center for post-exposure prophylaxis doses. To qualify for monoclonal antibody therapy, patients must have mild to moderate COVID-19 with positive PCR or antigen testing. They have to present within 10 days of symptom onset. Patients must be either outpatient or hospitalized for a different reason other than COVID-19. And then lastly, they can have no new or increased oxygen or respiratory support requirement from pre-illness baseline. Additionally, patients have to be at least 12 years of age and weigh at least 40 kilograms and have at least one high-risk condition, which are listed here and include elevated BMI, poorly controlled diabetes, severe sickle cell disease, severe immune compromise, severe heart, lung, neurodevelopmental, and kidney disease are the qualifying conditions. So in addition to our internal guidance, we again worked as part of a multi-center collaborative to develop guidance on the use of monoclonal antibodies for the treatment of COVID-19 in children and adolescents. As you can see in the guidance statement, this is back from December 2020, we actually had suggested against routine administration for children with COVID-19, really due to a complete lack of pediatric data. However, since then, given newer data are now available, we've written and updated this document with recommendations on which patients may benefit from monoclonal antibody therapy. And this manuscript's been accepted for publication in the Journal of Pediatric Infectious Diseases, and I anticipate will be coming out soon. As I mentioned on the previous slide, newer data have emerged regarding which pediatric patients are at higher risk for severe disease. Recent publications have demonstrated that certain risk factors such as immune compromise, diabetes, congenital anomalies, and obesity are associated with increased risk for developing severe disease. And therefore, patients with these underlying conditions should be prioritized for monoclonal antibody therapy. In addition to the previously mentioned publications, our group at Boston Children's Hospital has been working on evaluating national data to determine risk factors for severe disease, specifically among adolescents aged 12 to 17. And the data I have presented here was from our presentation at our ID Week conference in 2020. This is a retrospective cohort study that analyzed adolescents reported in the Pediatric Infectious Diseases Transplant Network, which is the Pediatric COVID-19 U.S. registry between April 1st, 2020 and April 30th, 2021. So as I mentioned, this is part of the PIDTRAN, Pediatric COVID-19 U.S. registry, which includes patients under the age of 21 with laboratory confirmed COVID-19. This is a voluntary national registry that collects de-identified data with medical history and clinical data from medical records. It could be patients seen either inpatient or outpatient, and cases were submitted by clinicians via a REDCap survey. And all of this was organized at St. Jude Children's Research Hospital, which served as the data collection and coordinating center. In our analysis of the data, we found, similar to previously published data, that adolescents with immunocompromising conditions, sickle cell disease, technology dependent, so such as patients that have a tracheostomy or ventilator dependent, those who have obesity, diabetes, neurologic disease, and pulmonary disease, excluding mild asthma, or more likely to be hospitalized with symptomatic COVID, and we felt therefore should be prioritized for monoclonal antibody therapy. And then for the last part of the therapeutics discussion, I'll review our hospital's therapeutic approach to MISC. I am going to keep this portion brief because it was really our rheumatology section that led the effort in developing our management guidelines for MISC. So at our institution, the medications we may use to treat MISC include IVIG for children who present really with or without features of Kawasaki disease or myocardial dysfunction. So pretty much everyone with MISC is getting IVIG. Glucocorticoids for those who present with features of shock, coronary artery dilation, aneurysm, and or other organ-threatening disease, or MISC refractory to IVIG. Anakinra for MISC that has failed IVIG and glucocorticoids, or for patients with contraindications to glucocorticoids. And then lastly, canakinumab for IVIG for MISC in patients who require long-term IL-1 blockade. Our rheumatology and cardiology colleagues also worked with a multi-center group to develop the official American College of Rheumatology clinical guidance for MISC in children, with the treatment recommendations shown in the figure for the manuscript on this slide, which follow our own internal guidance as well for management of MISC. So now that I have reviewed our diagnostic and therapeutic approaches, I want to give a brief review of some Boston Children's Hospital specific data and how we've managed the patients we've seen to date. As of October 26, 2021, which is the last time I pulled these data, we've sent 129,439 tests, among which 2,817 were positive, so 2.2% positivity rate. The vast majority of these patients did not require admission or were admitted to the floor, though we have had many patients that did require ICU level care. And additionally, we've treated 112 confirmed cases of MISC to date. Among patients with confirmed COVID-19, we've only actually had to use remdesivir in 68 of these patients. We've used more monoclonal antibodies, actually. So we've given approximately 100 children and adolescents, mostly adolescents, monoclonal antibody therapy. We have given a few doses of post-exposure prophylaxis, and we've given a few younger children who are immunocompromised monoclonal antibody therapy via compassionate use. Now that I have discussed our diagnostic and therapeutic approaches, I want to pivot back a little bit to kind of the next logistical challenge that came out and review how we worked on the vaccine rollout processes. Before the vaccines became available via the FDA emergency use authorization, our institution had to develop a prioritization scheme for how to vaccinate our staff, knowing that we weren't going to be able to do everybody at once. So we did prioritize healthcare providers who were at most risk for exposure. So those included providers in the emergency department, those who do transport calls, providers in the ICUs and in our primary care clinics. And then we moved on to other front-facing providers and ultimately expanded to all other staff. The amount and type of vaccine we had available was completely dependent on the State Department of Public Health, who decided which vaccine and how much to allocate to each institution. So to date, we've actually had our staff vaccinated with a mixture of some have received Pfizer and some have received Moderna. We have had really high rates of vaccine uptake, which is great. and actually have recently made the vaccine mandatory for all staff with some exemptions like medical exemptions, which is no different than what we've been doing for our annual influenza vaccines for many years. We also planned ahead to be able to vaccinate our patients efficiently. So those who were leading our vaccine rollout collected patient names to gather lists of who would be eligible ahead of time to be prepared for our rollout. And as soon as vaccines became available for children 12 and older, we were able to quickly deploy the vaccine to eligible patients who wanted the vaccines. And then more recently, the FDA has authorized use of the Pfizer vaccine in children 5 and older. So we've used these same steps to quickly vaccinate our younger children now. So now that I've covered several of the logistical challenges, infection prevention and control measures, and our approach to diagnostic and therapeutics, I want to next discuss how we developed some novel programs in response to the pandemic. So in the early months of the pandemic, patients began to post on social media about symptoms persisting for weeks and then even months after acute SARS-CoV-2 infection. And these patients were able to find each other on social media and collectively coined several terms, including long COVID tail, and long hauler. And since then, the CDC has officially named this syndrome post-acute sequelae of COVID-19, or PASC. At our hospital, there was an increasing number of requests to evaluate patients with a history of SARS-CoV-2 infection, reporting a variety of persistent symptoms. To address this, we established a multidisciplinary Boston Children's Hospital post-COVID-19 clinic to address the needs of this growing population. And the goals of this clinic are to provide coordinated medical care, improve the patient experience, and gain a better understanding of what post-COVID-19 syndrome looks like in children and adolescents. I have to thank my colleague Alicia Johnston, who created these slides for Grand Rounds we presented together earlier this year at Boston Children's Hospital. These next few slides provide an idea of how patients with post-COVID symptoms are being plugged into appropriate care. Patients who are admitted to the hospital with MISC are subsequently followed up by cardiology and rheumatology. Those who need a return to clearance for sports are seen in our cardiology clinic. And those that had lung disease with their presentation are followed by our pulmonology colleagues. Those with other symptoms are followed in our infectious diseases clinic. As I mentioned on the previous slide, all other patients with persistent symptoms are seen in the infectious disease clinic. And in clinic, our evaluation consists of a history and physical, reviewing labs, reviewing exposures per other potential infectious diseases, and then determining if a patient had confirmed probable or possible COVID-19 prior to the onset of all of these symptoms. We have identified point people in each of the listed subspecialties who have helped identify symptom complexes that should prompt referral for evaluation by that subspecialty, and who can help facilitate timely appointments within each of these subspecialty clinics. What we have seen is that many of these patients have symptoms that wax and wane and change over time. So some symptoms resolve, others appear. So in order to make sure that we're addressing everything, we do schedule a follow-up clinic about 4 weeks after the initial visit to reassess and see if any other services are indicated. Now that I have discussed our post-COVID clinic, for the last portion of my talk, I'll review one other novel program that has emerged as a result of the pandemic. Our group was actually awarded grant funding to develop a cluster of research excellence specifically to study emerging pathogens and develop pandemic preparedness. This group consists of members of our infection prevention and control team, the antimicrobial stewardship program, the microbiology lab, and several of our infectious disease researchers, again, really to prepare for potential future pandemics. So for my conclusions, there are several key points that I feel have allowed us to be successful in our response. These include working together both in our own institution, but also coordinating and learning from other institutions. I think that was really key in our response. Planning ahead when we were able to, such as with the vaccine rollout, that was really critical to help keep us efficient. The ability to have in-house testing was super helpful for patient management, but also infection prevention plans. And as a result of this pandemic, we've been inspired to develop novel programs to really help be better prepared for future pandemics. And lastly, we're now using what we've learned in order to study and better understand and better prepare for future pandemics. I do have many people I'd like to thank for their amazing efforts. This includes our infectious diseases diagnostic lab, infection prevention and control, our antimicrobial stewardship program, the whole division of infectious diseases, everybody at Boston Children's contributing to our COVID-19 response, and Dr. Manu Chaudhry for inviting me today. So I'll open up for comments and questions and discussion right now.
Thank you so much, Gabriella. Really comprehensive your experience. There are some questions in the pop-up window. I'll just take them for you.
Okay.
Dr. Deepak is our another intensivist at Rainbow Children's, and he has a specific question. How late into the illness did you use remdesivir, and how long? For how long?
That's a good question. We actually have not limited it to how late in the illness. If someone was coming in and tested positive via PCR testing, which is what we're using in our institution, and had an oxygen requirement, we would still offer to use it with the family and discuss it. We're typically using 5 days. Some of our patients have actually gotten shorter courses. We've had several teenage patients that come in and are on BiPAP for like 48 hours and get remdesivir, and within a couple of days are completely back to baseline. So we have not mandated that they stay in the hospital for their entire course. But once they're back to baseline and not needing supplemental oxygen, we've allowed for shorter courses. But for the most part, most children are getting 5-day courses.
Akshay has a couple of questions. Dr. Akshay, you want to ask?
Yeah, there's quite a few questions I wanted to ask. One question is about the monoclonal antibody program, what you just mentioned. So just curious to know, because one of the things about monoclonal antibody is how fast you give it in terms of the diagnosis, right? So one of the challenges have been the delay in RT-PCR reporting and how it might impact the effectiveness of monoclonal antibodies. So just curious to know, how is it you went through this in terms of identifying patients who needed it, and how fast were you able to give monoclonal antibodies?
So we definitely are fortunate right now in that our turnaround time for testing is very rapid, which definitely helps. Actually, several of our patients have been referred from the community, like community pediatricians that have a patient that might have a very elevated BMI. We have a hotline that they can call, and then they get referred to a form that they fill out the patient information. It's reviewed that day by the clinical committee to say, is this patient qualify or not? And then the family gets a phone call to schedule. Because actually not that many patients have been referred, like as far as a cluster, we've been able to fit everybody in who responds. Unfortunately, there have been a couple of patients where, the family, it was hard to get in touch with them. And then all of a sudden they were day 12 of symptoms and we weren't allowed to actually give them the product. So there were a few patients who missed out just because we couldn't track them down. but it's been more of a trickle than kind of a large volume at once. So we fortunately haven't had too many issues fitting everybody in.
And
In terms of sorry, go ahead.
sorry, Dr. Akshay, just on the same lines. So if you are, now that we are, 2 years down into the pandemic, there will be a lot of seroprevalence. Do you check their antibodies before giving them monoclonal antibodies? And the second question is, if like they end up needing oxygen, do you you stop it and then give remdesivir? How does that transition take place?
A good question. So we have not routinely been checking antibodies, and it's not one of our criteria for inclusion or exclusion. So if someone was known to have antibodies, it doesn't exclude them from receiving the therapy. I'd say most commonly the patients that we have been giving this to have been either very overweight children that community pediatricians have referred to us, or are very medically complex kids, so our oncology population, the trach vent dependent kids. We fortunately so far, I've actually looked through really all the patients we've given monoclonals to, nobody has developed an oxygen requirement while receiving it. But I do imagine that we would pause the infusion if someone developed a new oxygen requirement while getting the monoclonal antibodies, but we haven't come across that yet.
How late you might want to wait to give monoclonal antibodies, Gabriela? For example, if a child comes with a COVID positive report and it is almost 3 days, would you still go ahead and give, or is there a ceiling time beyond that we say, oh, it's of no point using monoclonal antibodies now?
We have been giving it up to 10 days from symptom onset, which is in line with what the FDA has kind of allocated as appropriate use.
And why do you think the negative pressure room to give the antibody?
I think we are doing still airborne precautions for anybody that tests positive for SARS-CoV-2. Yeah, that's why. And I understand it's possible everywhere, but that's been doing.
Yeah, so a couple of other questions I had was related to the post-COVID issues. One of the observations what we had with regards to at least the tropical diseases like dengue fever and rickettsial illnesses is that their nature has changed. That's our clinical observation post-COVID, especially those who have COVID seropositivity. So we find that some of them are unwell or their illness nature has changed. That's been the observation of most of the physicians and pediatricians across the country. I just wanted to know your thoughts. Is there similar kind of an observation in terms of how these other infectious diseases behave? Do they behave in the same way, or have you seen any change in the nature of the presentations?
So at least here, we don't see any dengue, but what we do have a lot of here that I think from our perspective is very analogous to this post-COVID syndrome is Lyme disease. We're highly endemic from Lyme disease, and we do see a lot of patients after having been diagnosed with Lyme that can have really persistent symptoms that still is incompletely understood. And we do really a similar kind of evaluation, not giving any more antibiotics, but it's a lot of getting them plugged into the right specialty for physical therapy or different stuff to really improve chronic fatigue, joint symptoms, etc. I haven't seen changes as far as different presentations in other infectious diseases in patients that have had COVID. So that's not something I've seen. I'm curious, what differences have you seen with these other infections?
Yeah, so the interesting part about dengue fever is we've seen kind of a combination of MIS-C plus dengue. So oftentimes you would see the fever would settle down by 4 to 5 days, and the CRP doesn't tend to rise in dengue fever. But we have seen children who have fever persisting beyond day 5, who have features of MIS-C in terms of your ferritin levels being high, CRP being persistently high, fever continuing, and they seem to respond to a very short duration of steroids. And we have seen a lot of children who present with neuro MIS-C features, but also turn out to have scrub typhus IgM positive. Now it's very difficult to interpret a lot of these reports because there's a lot of anamnestic response which tend to happen with once you're COVID seropositive. But a lot of them, some of them, even clinically, the kind of rashes you see, the vasculitic rashes you see, they seem quite similar to rickettsial fever. So it becomes incredibly hard at the bedside to really differentiate between these illnesses. So yeah, those are the ones we're seeing more often.
That's interesting. It's like people are having more of an inflammatory response to typical. Yeah. That's interesting.
And interestingly, we had one child, Gabriella, who had Aspergillus pneumonia post-COVID. Absolutely immunocompetent patient, and he came in a florid HLH picture, and the dengue serology was positive, COVID serology was positive, and subsequently the CT scan and bronch revealed florid disseminated Aspergillus infection, and we subsequently lost that child. So we kept wondering if, like in adults, they see this T cell exhaustion, lack of recovery of T cell, and how on third week of illness they do develop Aspergillus pneumonia. And we're just wondering, despite having an asymptomatic COVID infection, does the T cell dysfunction happen? Because it's described well in sepsis that it can last up till a year. Do we see very similar kind of things in post-COVID? So these are thoughts we are going through. I just would wonder to know your thoughts too about it.
I agree with you. I think there's a lot on the immunophenotype that we're still learning. So actually one thing that we have been doing that I didn't mention is really any child that's requiring admission for COVID, our immunology team is getting on board and at least making sure some basic immunology information is collected. Should eventually have data from that to hopefully better understand what's going on.
Did you see co-infections like staph aureus and all, like MRSA? We had one MRSA which we could not get that child back, and we were in discussion over phone, Gabriella. Did you see any such experiences where like co-infections really made it difficult for you guys?
Yeah, so actually I would say with our first wave, we really didn't see co-infections at all. But with the Delta wave, we've definitely have noted more co-infections, and I've definitely had multiple patients where COVID was complicated by MRSA pneumonia specifically, and really bad, like large empyemas, bacteremic with it, so pretty aggressive MRSA disease. And the reason we were able to detect it, it was almost like, the patients when they get influenza, were doing better, and then all of a sudden, they're having fevers again, they need respiratory support again. So you get a chest x-ray and they've got big focal consolidation and big empyema that have grown MRSA.
It's interesting. I think Manu would agree. I think the similar experience we had was with Delta wave, and with the first wave, we barely had any of these illnesses. It seems like it's more of a characteristic of a Delta illness. And I know we are short of time. I just have a couple of questions. One of the difficulties we had was how do we manage a child who's COVID positive in the hospital with the family members not being positive, and how did you manage communication with the family members? And the last question is about your post-COVID clinic, and I think that's a very interesting thing. I just want to know briefly about your experiences in terms of what were the common post-COVID symptoms you noted in your post-COVID clinic.
Yeah, so as far as the patients that were positive for COVID, the parents were allowed in the room. They were expected to wear masks whenever we enter the room. And they've been in negative pressure rooms. And then the parents were not allowed to leave the room and go around the hospital. So they were confined to that room. But they were allowed to be there, or have been allowed to be there as we continue to see patients. As far as post-COVID symptoms, it's a lot of there's a lot of variety and kind of vague symptoms. So a lot of fatigue, GI symptoms, poor appetite, feeling muscle weakness. So again, really from our perspective, really similar to when we have patients that have been complaining of Lyme symptoms for a while. So it's very interesting to us.
Can I ask one last question?
Yeah.
This is interesting. Have there been any concerns of MIS vaccination because antibody?
It's a good question. We actually had a patient that had been vaccinated and came in with a diffuse inflammatory response, ultimately thought to be a different etiology, but the question did come up because there's been some description, at least in the adult population, of like MIS-A, but so far we have not had any officially confirmed MIS-C cases post-vaccination. We did see several cases early on. This is totally dropped off of the post-vaccination myocarditis, but eventually these kids got so comfortable with it that most of them were so mild that they were able to go home on like NSAIDs and just follow a cardiology clinic.
Thank you so much, Dr. Gabriela Lam, for joining us today and sharing so extensively our whole journey through the pandemic. And I know during this whole pandemic we were exchanging so many ideas, what you guys were lacking and then what I wanted to know, and then sharing with my team. So thank you so much for coming up here and sharing it again with us on the platform.
Thank you, Mario. Thank you, everyone.
Thank you so much. Thanks a lot, Gabriela. Have a nice day.